Thank you again to everybody for joining the panel. I'm aware that we're running about 20 minutes late, but I think, Sean, you were happy for us to carry on and people can dip in and out if they need to.
No, absolutely, yeah.
So we've still got 220 people participating, which is brilliant. So thank you to everybody for staying on. So we're going to change tack a little bit. We're going to talk a bit more about surgery and some of the challenges that we might face in otological surgery, particularly around tympanoplasty and cholesteatoma surgery. Why won't that change? Hang on a minute. Oh, there we go. So I think everybody's has met Simon Freeman and Emma now. Rob Harris, I don't know, do you want to just say a few words about who you are and where you're from, and then Anand, if you could do the same?
So I'm Anand Kasbekar. Can you hear me, Simon?
Hey Anand, yeah, we've got you now. Brilliant.
So I work in Nottingham as an otologist. I've been here for the last few years.
Great, thank you very much. And Rob, are you around? Not sure.
Yes, hello.
Oh, you're there. Brilliant.
Can you see
me? Rob. Yeah, we can see you.
That's okay. Good. All right. I'm Rob Harris, ENT consultant from St George's Hospital. Been a consultant for 10 years there.
Great. Thank you very much for joining us. So I'm just going to start off just by talking about nomenclature, if that's all right. Just because there's a lot of confusion around it, and certainly for the junior trainees, I think it helps just to try and clarify what the correct terminology to use is around chronic otitis media. So, I mean, there's lots of terms being used historically. We've used safe and unsafe as descriptions for chronic otitis media. I think these days we're well aware of the fact that actually mucosal chronic otitis media and cholesteatomatous disease probably have a very similar complication rate. So both types of disease are safe and unsafe depending on the circumstances. And similarly, terms like tubotympanic disease and atticoantral disease, which were used historically, probably aren't all that helpful either, because certainly for cholesteatomas, they're not confined to the attic and the antrum, which is really what the presumption was with the term atticoantral disease. So we've tried to not use those terms either. And what we've been trying to move towards is dividing up chronic otitis media into three main groups, really. One is mucosal chronic otitis media, which essentially just means that there's a perforation, and that can either be active or inactive, depending on whether that perforation is associated with an infection. And you can see there a typical perforation, which you'll all be pretty familiar with that. And then the other type is squamous chronic otitis media, which again can be active and inactive. I think this classification is a little bit difficult because active is easy because that's a cholesteatoma. Inactive is described as a retraction pocket, but you can have some retraction pockets that are actually stable and they would fall into the healed group really. But the inactive squamous chronic otitis media are really the retraction pockets that are kind of at risk of developing into a cholesteatoma. And then the final group are the ones that have healed. So this is a typical example of a healed middle ear dysfunction. You can see that there's obviously been a lot of eustachian tube dysfunction over the years, but the eardrum has stabilized, albeit in a fairly retracted and fairly horrible looking way. But it's not collecting any debris and it's not causing the patient any problems. So they're not going to run into any difficulties with that ear. And similarly, there are lots of terms used when you're describing mastoid surgery. So historically, we've used atticotomy, combined approach tympanoplasty. I don't know about you, but I found the term combined approach tympanoplasty really confusing when I was an SHO. I had no idea what that meant. People have used closed and open cavities, radical mastoidectomies. You know, you can find out what the definitions of these are by going through the literature, but they're not really very helpful in describing the operations that we do. And also, finally, the facial ridge. You know, you'll probably be familiar with that term, but it's not an actual anatomical structure. It's actually created by surgeons who don't take the canal wall down properly after a mastoidectomy. So if we can avoid that term as well, that would be ideal. So there's just a summary here of some terminology that probably is more helpful, and it basically divides up cholesteatoma surgery into two groups: the intact canal wall group and the canal wall down group. And you can divide those two into front to back or back to front, depending on whether you do your dissection from back to front or front to back. So for the intact canal wall group, if you do a front to back mastoidectomy, you're essentially starting off with an epitympanotomy. And if you're doing something a little bit more extensive, you're going on to an epitympanoantrostomy. If you're doing a back to front, you start with a cortical mastoidectomy and then go on to do a posterior or a superior tympanotomy. And then for those that want to do canal wall down surgery, that's just simply called canal wall down tympanomastoidectomy. And in each of those cases, you'll need to do some sort of reconstruction or maybe obliteration. And which approach you use is very much a personal choice, but it's determined by the clinical situation and the radiological features as well, and also to some degree what you find in the operation. So that's just a quick summary of some of the terminology that I think is helpful to use. I wanted to go on now just to talk a little bit more about tympanoplasty and the approaches that people use. So obviously over the last few years, endoscopic surgery has become increasingly popular. What's the panel's opinion on approach? Simon, what do you offer your patients when you're carrying out tympanoplasties in terms of approach?
It depends on the anatomy and the perforation. For a subtotal perforation, I've always tended to do a full post-oral incision, lift the whole drum, take it off the malleus to a big cartilage shield or Patman graft, whatever you want to call it, and then an extra layer of fascia, and really go to town on how robust the repair is. And then for little perforations, I've fiddled around with butterfly grafts. I found them a bit difficult with if they're near the malleus or the annulus to get it to settle down. I have been fiddling around more with endoscopic approaches. You definitely get a nice view. It's lovely for teaching, but it's quite tricky trying to operate with one hand. And I'm used to harvesting simba and fascia, which you can get lots of with a post-oral incision. But if you're doing it permeatally, then I'm stuck with just tragus. So my experience is still limited and growing with that.
Rob, are you of the same approach, or do you have a more endoscopic type of practice these days?
I tend for Laryngoplasty, I tend to do mostly through a permeatal approach.
Okay.
I find that I can get access for even quite large perforations in most of the time, and use tragal perichondrium, or if it's a larger perforation, just a little incision above the ear to take some temporalis fascia, or use a little bit of tragal cartilage. If there's a very big anterior overhang and it really isn't visible, then I would do a post-auricular and drill off the anterior canal wall. But yeah, I found I can do most of them permeatally. And without the use of the scope for laryngoplasty. It's really useful for getting a better view in cholesteatoma surgery. It doesn't help you get the disease out, but it does help you get a really fantastic view and help in sinus tympanoid areas like that. But I guess we'll come on to that part of the conversation later.
And Emma, are you using endoscopes more, or
yes, a lot more. So I now do primarily endoscopic approaches for pretty much all my laryngoplasties, tympanoplasties. I was of the opinion that I should use cartilage all the time, as our training in Cambridge has taught us. Basically, it was just cartilage everything. And they didn't thin the cartilage down and didn't find that the hearing results particularly changed, but I'm sure we'll talk about that. I do think it makes a difference. I would use probably something that you would, if you're still doing the same thing, is tragal cartilage with perichondrium attached, exactly as you've shown there. Checkerboard it. If it's a large perforation and you need to fit it around the malleus, that's when it gets a bit more tricky. You have to, take out that bit of cartilage so it fits in with the handle of malleus. And it's difficult with the purely endoscopic approach, one-handed. But yeah, so I would do that in most cases, unless it's a very small perforation and it's a primary repair. Then I might just use perichondrium on its own.
Okay, so some of us using cartilage, some of us using perichondrium, some using fascia. Is anybody using any alloplastic materials for tympanoplasty? So a lot of the endoscopic surgeons are using that now, aren't they? So they don't have to do any incisions; they can just use that, and it seems to work. If you speak to the guys in Birmingham, some of them are getting good results with alloplastic materials. But I think the literature basically suggests that in terms of closure of the tympanic membrane, probably cartilage is the most reliable. There was quite a good systematic review in 2016 that showed that cartilage has a 92% success rate compared to 82%, and you can see that on the box plot on the right there, with the vast majority of the studies showing that cartilage was more reliable than fascia. So yeah, I think, certainly in my practice, I'm still sticking with cartilage for pretty much everybody. So I just wanted to ask you what your approach to some of these different situations would be. So this is a tiny perforation, a pinhole perforation. Who would use a normal tympanoplasty technique for that, and who would use a butterfly graft? Okay, Anand, Rob, what would you do?
I would
Butterfly.
Standard technique. I'd raise a little flap and just tuck a bit of tissue underneath the eardrum.
Okay, Anand, what would you do?
So I would either use a butterfly, use a bit of cartilage and shape that into a sort of little grommet butterfly sort of wedge, or I'd fill the middle ear with some spongistan and then put some fascia in there without raising a flap.
So you just freshen the edges and tuck it through. Yeah. So I just got a little video of a butterfly. It's actually a cadaveric video, but it just quickly shows you what's involved with the butterfly graft. So you can see the cartilage here. This was taken from the Simba, but you can take it from anywhere. And you basically just make a groove along the edge of the cartilage, and that's why it's called the butterfly, because you're just sort of separating it into two leaves, and then you basically slide that in. You freshen the edges of the perforation up. You have to be a bit careful about the size of the perforation, because if you make it too big, then sometimes these grafts don't sit very well. But basically you want the internal leaf to be inside the drum, and then the external leaf to be outside the drum, and it sits there really nicely. And you can get some pretty good results. I've never had a problem with it, and it's much quicker than doing a normal tympanoplasty for those very small perforations. Okay, so this is a slightly larger perforation, and it's very anterior. What are the sort of issues that you might have to deal with that drum? Rob, do you want to just give us your thoughts?
Yeah, well, the issue is supporting the graft anteriorly. Broadly speaking, the two options are to pack the ear with spongostan, which I prefer not to do, because I don't think that I prefer to try and ventilate the middle ear while it's healing. And also because everything will get dragged down towards the eustachian tube with the mucociliary motion. And that's sort of the deepest area of the drum. So you're sort of stacking up quite a lot of tissue there. So the alternative is to do an antero-superior pull-through.
Mm-hmm.
It needs to be anterior-superior, so that the direction that you're pulling the graft up is parallel to the hand of the malleus. If you try to pull it up directly in front of you along the anterior canal wall, what tends to happen is that you end up with blunting, and also a gap from lateral to medial between the edge of the superior edge of the perforation and the graft. So it really needs to be sort of a V-shaped graft which gets pulled up underneath the annulus superiorly and is anchored really circumferentially. So you elevate the annulus, leaving only a vascular flap either medially or superiorly to allow you to get that graft under. And because you can see the annulus, I know this is a telescopic view, but if with that sort of view, if I could see that through the microscope, then I would do that permeatally.
Yeah, I mean the difficult area is this bit here, isn't it? Because you've got the malleus, which is very difficult to get underneath and get good support in that superior part. So yeah, that's important to support that anterior and superior portion. Sometimes I use a bucket handle flap for the big perforations. We'll go on to that in a minute. But does anybody else do that? Do they raise a almost circumferential flap, just leaving it attached with the vascular strip where the malleus is? And that can be a really helpful approach, I think.
I do a wide incision, but I tend to base it anteriorly rather than superiorly.
Okay, yeah, great.
Same thing otherwise.
Yeah, so this is the ultimate tympanoplasty, really, isn't it? You know, these are the really difficult ones. Does anybody want to just say what the challenges are? I mean, to me, there are two major challenges with that sort of tympanic membrane. What would you say are the issues? We've talked about one, haven't we? The anterior superior support. What's the other problem with these perforations? I think it's the malleus, isn't it? It becomes foreshortened and angled inwards. So getting a graft underneath the drum to sit well is quite difficult. So how would you deal with a perforation like that?
Who are you addressing that to?
Anand, do you want to give us your...
Yeah, Simon, so just a wide tympanomeatal flap. I would use tragal cartilage with perichondrium. I'd have to make sure that when I took the graft, the perichondrium was wide enough and big enough, because I often find that when you're trying to, as you say, when you're trying to fit that cartilage in the gap around the malleus, that it doesn't fit properly, and you end up with little gaps, especially in that superior aspect. And then I would hope that the perichondrium flap that I'd left around the cartilage attached would then fill in that gap. You know, it's not as good as cartilage, but it would hopefully stop any residual small perforations. And I have to be quite careful that my cartilage graft wasn't stenting the ossicles, because that's the other problem. I would definitely make it a little bit more malleable by scoring it. And that you can do quite nicely. The perichondrium is still attached to the cartilage. If you take the perichondrium off the cartilage, then you're dealing with a separate piece of fascia and a separate piece of cartilage, which then the cartilage itself then underneath can fall down onto the incudostapedial joint.
Simon,
so anyway,
anything in particular that you would do?
Yeah, I mean, as I said, I tend to, with subtotal perforations, use a separate piece of cartilage and fascia. The difficulty here is the short malleus. Usually I rely on the malleus to support the cartilage and get it into the right position. Whereas once I've lifted everything off here, it's difficult to say, but my guess is that malleus isn't going to hold the cartilage up inferiorly. So I would probably then just use a bit of Spongistan inferiorly. I try, like Rob, I try to minimize the use of Spongistan, but I don't mind using a bit if it holds the cartilage in the right place and just tries to keep that middle ear space aerated. I try and use it inferiorly to try and keep the aeration pathway from the eustachian tube open.
Yeah.
And then I'd lay some fascia separately, because I just find that cartilage just has that slight tendency to fall away at the edges, and you can get little residual perforations just at the edges. And if I use a separate fascia, I find that that's not a problem.
And do any of you actually lift the drum off the malleus and then put the malleus, put the graft on the malleus, and then, so it's a sort of underlay sort of technique?
I do every time.
Sometimes.
I mean, I find that really helpful. I mean, increasingly for an anterior perforation, I'll do that even if it's not a subtotal. I was just going to show a little video actually, just to illustrate what I mean. So this is a tympanoplasty. It's a subtotal perforation, and basically you can see the drum being elevated off the malleus here. And by doing that, you're basically giving yourself really good access to this superior superior anterior bit. And then what I usually do for this is just do a sort of Pac-Man graft where you take a little a rectangle of cartilage out to accommodate the malleus, and you basically put that onto the malleus underneath the tympanic membrane remnant, and that just gives you the support of the malleus, but also gives you a really nicely placed anterior superior support for the graft. It's only another few seconds.
So Simon, the fear is that you leave some squames behind in the middle ear.
What, on the malleus?
How do you make really? Yes.
Yeah,
You're going to put a graft on top.
That is a risk. I suppose you just need to be careful about how you elevate it. And if you're really worried, if you've got a laser, you can always laser the malleus just to make sure there's no squames left behind. But the only bit that's difficult to elevate is that bit at the umbo. The rest of it just almost sort of unzips as you're doing the dissection, because there's quite a nice sort of plane between the malleus and the drum.
A very useful tip I was told a few years ago by Pete Valentine: size the periosteum on the malleus before you start. And it almost looks like there's nothing there, but if you get a sharp needle, which might be difficult, of course, on our theatre kit, but occasionally the tip of the sickle knife will do, you can score it and then use a Beals or a Hughes, and you just elevate that plane, and it actually gives you a different plane to if you're just trying to lift the drum off. And with using that technique, I don't think there's any risk of leaving squames behind, assuming it's not retracted.
Yeah, no, that's fine. Okay, brilliant. So just one more quick bit of advice. So this is a perforation in a drum that's pretty diseased. How would you deal with that, Rob? Anything in particular? Would you delay the operation just because it's inflamed, or would you just get on with it?
Well, it kind of depends. You know, some people's ears are like that all the time, and if you're just, I don't know whether you're doing them any favors by delaying it. But yeah, if you've got the chance, treat it with some steroids and antibiotics and get it in the best possible state that you can. I mean, I can't see that picture terribly well, but it looks like it's got sort of thick middle ear mucosa, but it's not particularly discharging. There's no sort of pus there, is there? He's the other concern with this ear is the amount of tympanosclerosis. You need a blood supply to get the skin to grow over whichever graft you're going to use, and the chances are that when you try to freshen those edges, you just find calcium, and very little chance that it's going to bleed and heal over. So probably as part of the procedure, that tympanosclerotic plaque is going to have to come out largely in order to promote blood supply, which is a bit like cracking a few eggs to make an omelette. You've got to make it a bit worse first, probably.
Yeah.
Try and take it out of the middle layer and leave the other layers behind. But often you end up with a significantly bigger perforation you started with. But yeah, you could repeatedly try to put a bit of graft cartilage in there and just find that it just won't heal because the new tissue won't grow over.
Yeah. Anybody else deal with that in a different way? I mean, I agree with Rob. I think I would rather deal with a bigger perforation with nice fresh mucosal edges or epithelial edges than having to try and get that to heal as it stands. Simon, Anand, what are your thoughts?
Yeah, agree with Rob, really, that tympanosclerosis will almost certainly fall away as you're freshening the edges anyway, and you'll end up with a much bigger hole. As opposed to the infection, as you say, it doesn't look, it doesn't look awful. And I'd have a discussion with the patient and give them the options, and then almost let them decide, really.
Simon?
Yeah, the same. I would probably try to take that tympanosclerosis away and risk a bigger perforation. It's quite a little bit of tympanosclerosis I don't worry too much about, but that's a pretty big piece, and I think it's going to get in the way.
Yeah.
An infection, yeah, I mean, I would try and treat medically first, as we all would, but if they turn up on the day with a discharging ear, well, I do plenty of reconstructions in cholesteatoma surgery, and they work fine.
Yeah,
so
I think that's true. Yeah. Okay, brilliant. So that I'm going to leave tympanoplasty now. I'm just going to go on to cholesteatoma and talk about some of the decision making. I mean, it's not going to be exhaustive because we've not got that much time, but I've just put a list of the key surgical issues here to try and optimize success. So you've got to make sure you understand what disease you're dealing with. You've got to make sure you've got adequate access to it, and you've got to obviously make sure you've removed all the disease, and then you've got to make sure that you've repaired whatever defect that you've created or the disease has created, and then think about what you're going to do with the hearing as well. So there's a few things there to think about. We're going to focus mainly on the first four. So first of all, maybe Rob, what investigations do you do? I mean, obviously we do a pure tone audiogram. Are there any imaging modalities that you use before you do a cholesteatoma surgery?
Yeah, I like to do a CT. Just gives you a little bit of information about what might to expect and helps you to counsel the patient as to what you're expecting. Really interested to see the state of the vesicular chain and how much space that there is around the vesicular chain in terms of the chances of preserving ossicles. My ethos is to try to preserve as much function in these ears as possible, and the use of the laser has made vesicular chain preservation much more possible now than I think it was perhaps 10 years ago. And your access really depends on the level of the dura and the sinodural angle to do that. It'd be pretty unusual for it to be so tight that I would do a front to back, a canal wall down. Even very small cavities, I try to do them canal wall up. Yeah.
Anand, do you think there's any role for pre-op MRI in patients that have got cholesteatoma?
Okay, so the first thing about diffusion weighted MR scan is that unless you've got a unit that has good results, it doesn't help very much. And we know that that's variable across the country. Secondly, so I would only do it if there's disease going into weird and wonderful more medially, around the otic capsule, of further in, and that I may need to involve a skull-based surgeon for. Yeah. But otherwise, no. But I would look at this obviously for second looks.
Yeah, I mean, I think I'd agree. I don't know whether you agree as well, Simon. I can't really see a role for MRI imaging if it's just confined to the middle ear. Where it is very helpful preoperatively is if you've got much more extensive disease. I mean, this was just one of our cases from a few years ago with a cholesteatoma that had basically destroyed most of the temporal bone, and it was really helpful to know whether or not the carotid artery was involved, what damage had been done to the otic capsule, which is basically all of it's damaged. But it can be helpful in certain extreme situations, but probably not that useful in the everyday circumstances. So what are the key things that you need to identify on a CT? I think Rob touched on that, but Simon, do you want to just say, in terms of the cholesteatoma itself, what sort of things do you look at? And then we'll move on after that to surgical planning.
Yeah, I mean, I principally with a CT, I'm looking at the surgical anatomy and whether there are indicators for extent of disease. So it's very useful for determining the height of the dura and the position of the sinus, which might help me determine, well, that's my principal way of determining whether I'm going to keep the canal wall intact or not. And then extent of disease, obviously it can't tell you the soft tissue extension, but it will tell you unusual bony erosions. So, you know, I mean, it's really good for looking at the ossicles in most cases. You can't always tell whether there is a stapes intact, but more often than not you can. Might be quite tricky to tell whether the incudostapedial joint's intact, but it's going to help with things like fistulas and tegmen exposure, and it'll give you an idea of whether there are odd erosions suggesting that this might be a skull-based cholesteatoma. And as you say, I wouldn't usually do an MRI except where we're wondering whether there's skull-based disease.
Yeah. Okay. So yeah, you've pretty much covered all the bases there. I think I've just got a couple of slides just to help illustrate those points. So, I mean, one of the key things if you're thinking about doing a canal wall up operation is whether or not you've got a mastoid that you can actually access the disease through. So this is two extreme examples. On the left, you've got one that's really lovely in terms of pneumatization. You can see there you get great access through a posterior canal wall up approach. But for this one, there's no air cells at all. The access through the bone to the antrum and the posterior tympanotomy would be really difficult. So maybe that one would be one to consider a front to back approach, because you're unlikely to end up with a big cavity, so you should be able to reconstruct that. And then similarly with the sigmoid sinus, Simon mentioned that it's really important to know where the sigmoid is. And you can see on the left, there's this, again, lovely pneumatized mastoid with a small sigmoid sinus. But on this side, you've got a large sinus and then a diverticulum on top of it. And you can just see that you're not going to be able to get good access through a posterior approach in a case like that without significantly decompressing the sinus, which isn't something that most people would want to do. And then the other issue is the middle fossa dura. So most patients, you've got a good view into the antrum from posterior because the dura is relatively high, but there is a lot of variation anatomically, and the dura can dip down quite low. So you can see on the left a very flat middle fossa plate, but on the right you've got this middle fossa plate that's dipping down, and you can imagine that getting access to the middle ear through a mastoid when it's dipping down like that could be quite difficult. And I mentioned at the beginning of my radiology talk that looking at the relationship between the middle fossa dura and the lateral semicircular canal can be quite helpful. So you can see here there's a nice gap between the two. You can't really see the lateral canal so well on this, but you can imagine that the gap between the two would be much smaller on that right hand scan. Okay, so this is just to talk about what you would do for certain types of cholesteatoma. So on the left hand side, you've got a CT axial slice. I've only got one representative slice, so I didn't think we needed to go through a whole series of scans. And you can see that you've got this small cholesteatoma, you've got the facial nerve here. It looks as if it's still in its bony canal. It seems to be mainly medial to the vesicular heads. So, and you know, obviously I haven't got all the slices, but it looks like quite a sclerotic mastoid. Anand, what would your approach be to something like that?
So again, it depends on when the CT was done, because a lot of these are done months previously and maybe over a year, and then you don't know whether it's a lot more extensive. In something like this, it would seem a combined approach might be difficult. I don't have all the slices, but certainly I'm a combined approach person. I know you don't like the terminology, but that's what I would do. I would do a post-oral incision, lift up the tympanomeatal flap, inspect the ossicles, see whether I could get the disease out. If and you know, if I'd make a quick decision on whether I could save the chain or not. Probably not if it's sort of medial to the ossicles, and I would take the incus out, take out the disease, and depending on how large the cavity was, I would either fill it with some bone dust, with blood and tissue mixed in, or and then cartilage on top. But you know, make sure that I've removed the cholesteatoma. But if it was, yeah, so that's what I would do.
Okay, Simon, what would you do for that?
Yeah, I mean, I would, I guess, do something fairly similar. There's concern that the cholesteatoma is medial to the ossicles, so it may not be accessible without removing the head of the malleus and the incus. I'd have a look via the middle ear first to try and work out what I was dealing with. If I could persuade the nurses to get the endoscope kit out before I remember to do it at the beginning of the operation, I'd probably have a look with the endoscope first, but otherwise have a look with the microscope, lift all the flap up, just maybe trim the edge of the scutum and just see if you had a good view, see if it could all be taken out via that approach, which it might be. You can see there's good aeration in the antrum. But although, as Anand says, I'm always very open to the fact that the iceberg phenomenon occurs, and it ends up being much bigger than I thought. Yeah. And then if I have to approach it from the mastoid, do a cortical, and if there's very low dura, then you know, maybe a front to back with limited disease, or canal wall down, back to front with extensive disease. But obviously that's quite limited.
Yeah. So, I mean, it's probable that the acicular chain's intact in this case, isn't it? So it's always a bit frustrating to think you've got to take out the acicular chain to get the disease out. Rob, you're a big laser fan. I'm increasingly a laser fan. Do you think you could get that out with a laser? And stay? And
it's hard to know, but I would, yeah, do my absolute best to get that out with the laser without disrupting the acicular chain. When you look at that, the likelihood is that they've either got normal hearing, or perhaps there's a little bit of a tamponade effect that's just mildly affecting the hearing. Yeah. Whatever, if you take the chain out and you put a PORP on, you've got, what, 80% chance of getting reasonable hearing, and definitely not on high frequency. So you're going to really disrupt him functionally. Yeah. And actually, although the airspace is small, if you were to skeletonize the posterior cranial fossa up to the sinusoidal angle and the dura, you can often, even when there's a small aerated space, by taking all the bone up, create quite a lot of space to be able to put a mirror in above the ossicles, and get this sort of orthogonal view. You know, if you get right down onto sinusoidal angle and place your microscope in from there, your view is usually the medial surface of the ossicles. Now that bit anterior to the head of the malleus is really tricky, even if you've got good posterior view. And so sometimes what you have to do is an anterior epitympanotomy. So you basically do an atticotomy, but anterior to the head of the malleus. And occasionally, particularly for the congenital cholesteatomas, if you dislocate the anterior malleolar ligament and take the bone back to the TMJ, you can then get a mirror into that space and clear the area away by firing the laser off the mirror. And because you're burning the surface of the ossicle, it is you know, a reliable technique. I think John Hamilton's recurrence rate's about 5%. My results are about 7%. So I think the laser is a really important factor in the treatment of cholesteatoma. The scopes will help you see the disease, the laser will help you clear the disease from the ear.
Yeah.
And I suppose just one other point, looking at that, because it looks like you could probably get instruments in and lift the cholesteatoma up and forward. It's not very clear where if it's acquired, though, is it? I mean, it's surprising there's nothing lateral to the ossicles at all.
Yeah, it's
so perhaps a congenital cholesteatoma to begin with.
Yeah. Yeah, I mean, I think the laser does make a difference. I think maybe that might be difficult, but to remove it and keep the chain intact. But with a large extended epitympanotomy going right forward towards a TMJ, you probably would be able to at least access that and give it a go. But yeah, I think we'd have to see. Okay.
It may or may not be possible. Yeah, and that's the heartbreak of that sort of surgery. You can spend hours trying to preserve the ossicles, and then just have to acknowledge that after all that time you could have done the operation about 2 hours earlier by taking them out.
Yeah, it's interesting, isn't it? Because 20 years ago it was all about making sure that you take the incus out and not leaving it in there, because there might be squames within the incus that make the risk of recurrence much higher. And that's why people didn't use incus transpositions in cholesteatoma cases, but now we leave intact chains in all the time. So it's a definite change of philosophy over the last few years.
Yeah.
So okay, so this is a larger cholesteatoma.
I totally agree with you, Rob.
Hello?
Sorry, Anand, what was that? Anand?
Sorry, I was just agreeing with Rob that I do think that the laser is pretty crucial if you're dealing with cholesteatoma.
Yeah.
I do use it in areas where I've taken cholesteatoma out.
Okay.
And I think it does make a difference with recurrence.
So this is a larger cholesteatoma. You can see that this one's anterior to or lateral to the heads of the ossicles, and also extending into the antrum. I mean, this has got quite a big sigmoid sinus as well, so maybe the access is difficult, but you can leave that aside. So Simon, how would you approach that? Would you take a different approach, or would you just do a canal wall up procedure as you did for the last one?
I'd need to see what the position of the dura is really. With the big sinus and that suggestion posteriorly, access may be quite limited, and I may be more inclined therefore to take the canal wall down and give myself good access. I have pretty decent results with obliteration techniques. So I don't tend to be particularly wedded to canal wall up if I think it's going to be tricky.
How do you obliterate your cavities?
So with bone dust and an inferiorly based periosteal flap. So it's sort of based on the mastoid, and it comes up, and it includes temporalis fascia, ideally, if it's a primary case. Sometimes if it's a revision case, that may not be available, and it only goes up to the temporal line, and in which case I may need some deep temporal periosteum to swing round from superiorly. That's my sort of backup flap. I like to cover the bone dust with vascularized tissue rather than fascia, just because I had a couple of bad experiences with fascia where it melted away and I had to revise the cases. I know other people use fascia and seem reasonably happy with it. I guess the other option is cartilage, which people also use as a way of covering the bone dust, as it has a reasonably low metabolic rate. So that would be my backup option as well.
Yeah. Rob, do you ever consider doing a canal wall down with a obliteration or reconstruction, or do you always try and do a canal wall up procedure?
I tend to always try to do a canal wall up. I mean, some of those earlier scans you show, there's no way, obviously, if it's that small. And I do have a few cases in my series that are canal wall down. It's basically an extended aticotomy because the airspace is so small. But for reconstruction, for patients that have already got a mastoid cavity that they're having problems with, I've been using Bond Alive. which I think is a brilliant way of filling the cavity. It doesn't retract in any way. If you do have to go back in, you can clear it very easily. The tissues grow between it, so it forms this sort of firm, rubbery sort of consistent tissue, and cover it. I did for a little while use fascia lata, but it tends to sequestrate. So like Simon, I like to use something vascularized that I can fold into there, and I tend to use the fascia, periosteum on an anterior based vascularized flap to fold over, and you get quite a lot of tissue to really cover that area.
Yeah, great. Okay. So I'm going to just go on to a more difficult case now. This was a real challenge of mine from a couple of years ago. This is a guy, he's in his late 60s, early 70s, who had a modified radical mastoidectomy on the right side, and unfortunately got a dead ear following that. It was about 15 years ago. And the left ear hadn't caused him many problems, but he then presented with a sudden facial palsy on the left side, the other side. That ear was still hearing, amazingly. And when I saw him, he had a grade 5 facial weakness. He had a moderate sensory neural hearing loss and a conductive hearing loss. And these are his scans. So I'll just quickly go through them. So basically, this is the middle ear here. This is where the cochlea ought to be, and this is where the labyrinth ought to be. This is where the labyrinth ought to be. That's the cochlea there. You can see the cochlea is actually intact, but the labyrinth is pretty much destroyed. And I actually did do an MR scan for him pre-op. So this is his T2 weighted axial scan. You can see the cholesteatoma there. Cochlea is still intact, and this is his DWI scan, which confirms that it's definitely a cholesteatoma. So we've got a patient that's got a dead ear on the other side. This is his only hearing ear, and he's got a grade 5 facial weakness. Simon, what would you do?
Send him to you.
I was going to send him to you.
Oh, damn. So did you say the facial weakness was on this side or the other side?
No, it's on this side.
Okay. So, I mean, obviously that's a large fistula, which is of serious concern when you're dealing with an only hearing ear. I'd be much more open to considering a canal wall down and giving myself really good access. It looks like the dura might be exposed. The question is what to do with the fistula to try and preserve his inner ear hearing. And normally I would try to take disease off the fistula, and then I would lay a little bit of fascia and bone wax into the fistula to obliterate it. And much like I would a semicircular canal obliteration for other reasons. And I've had good success with that. But obviously in this situation, with it being an only hearing ear, that raises, is that an increased risk to hearing loss, to which I don't know the answer. And I think I just have to be very open-minded when I explored the ear as to what I was going to do. I'd counsel the patient very carefully that there was a significant risk, but frankly, if we don't operate, he's going to lose his hearing. So we've got to try and do something. And if there was a reasonable thickness of skin going across the fistula, then I might leave it and just work around it. But the problem I found is that when you get to these, the skin that's over the fistula is so fragile and friable that it's not really straightforward to leave it in position. And which is why I've tended to remove it and obliterate. So I just have to be very open-minded. And if I was going to remove it, be incredibly careful. No suction anywhere near it. Lots of dexamethasone. Just very, very careful removal of that area. And the nice thing about a bit of fascia and bone waxes. Then you seal it up. And then once it's sealed, you don't have to worry about it for the rest of the operation. You can get the suction out and remove the rest of the disease.
I mean, it turned out that it was enormous. The fistula was, completely destroyed the lateral semicircular canal. The vestibule was open. It wasn't possible to preserve the hearing. But obviously, the other issue is the facial nerve. I mean, Rob, what would you do about the facial nerve? He's got a grade 5 facial weakness. And the cholesteatoma surrounding the ending and
okay. Well, you've got to peel the cholesteatoma off the nerve, and presumably that sort of peeled away reasonably easily. It wasn't too stuck down, or did you find that the planes had been destroyed along the exposed nerve as well?
Yeah, it was pretty stuck, and to be honest, I'd kind of decided pre-op that I wasn't going to do too much with the facial because it was already pretty much all gone, the facial function. So with the extent of the disease, I went on to graft the facial nerve on the basis that it was unlikely that it was going to improve from that level given the extent of the disease. But yeah, he lost all his hearing post-op, and I'd already spoken to him pre-op that was likely to be the case. So we talked about a cochlear implant on the right side. So we went on to do an early cochlear implant on the right side, which he's done pretty well with. And then he's now got a clear DWI at 2 years. And a facial nerve graft with a facial function of grade 4. So, it's not as good as it could possibly be, but not too bad. Yeah, so it was a tricky case.
Did you have to decompress the nerve either side of the graft as well?
Or was
it just all exposed?
Just took it back to healthy nerve, and grafted it. Yeah. Okay, so this it's a shame Emma's not here. So I'm going to make this the last case because I'm well aware that we're running over time. So this is an interesting topical case. So it's a 53-year-old patient that presented to his local hospital with severe right-sided hearing loss. I think I can't see right-sided headache. And he had some hearing loss on that side too. There was a bit of attic retraction with some keratin accumulating on otoscopy, but nothing too spectacular. And then a CT scan was carried out, and this is what we found. So these are the slices. So it's the right ear. You can see this mass within the middle ear space, basically filling the whole of the middle ear. And somewhat bizarrely, there's some air within the sigmoid sinus, and if you scroll down, there's also some air within the jugular bulb as well. But the otic capsule seems to be fine. So, what are your thoughts on that?
This was actually my case with Emma.
Yeah, it was. So, yeah.
So I got the call at the weekend going, I know you're not on call today, but I really need someone to sort this patient out. So we teed it up for Monday for the two of us to do. As was just shown, it wasn't just the ear that was the problem. It was her breathing that was affected. Because of that chest x-ray, and she'd been gradually dropping her oxygen sats, and they'd wondered whether that she was getting septic emboli through what is effectively a Lemierre's syndrome from a thromboembolic IJV because of the air there. And they were managing with IV antibiotics. I can see the chat's popping up, and Ed Moon's already given the answer away.
I'll see the chat.
So anyway, we took this patient up, and we decided we would explore the neck to see whether it was worth tying the IJV off. And in fact, the whole thing was thrombosed, so we just left it alone. Then Emma explored the mastoid, and it was basically a fountain of pus, and a big hole in the sigmoid sinus and a big cholesteatoma. So she dealt with that. And then while she was in hospital, so she was then, the ENT bit was fairly straightforward. It was just a post-op mastoid. She was on critical care for the lung issue. And then this was at the beginning of March. On the 3rd of March, I think we operated. The COVID crisis hit 10 days later, and at which point somebody decided to test her, and she was coronavirus positive. So now we're wondering, oh, as that lung change is actually coronavirus and not anything to do with the IJV, and we don't know. So she got better. She did really well. Her lungs actually did okay, and following the operation, she gradually improved. And eventually, she had an echo and everything, and actually that was all right. Eventually, she was discharged home, and she's the local hospital are going to follow her up because of the COVID. We're going to see her in clinic when reasonable to do so.
Okay, well, I just wanted to finish off with a finale that was very topical.
You succeeded.
So
very interesting.
There are some other slides, but I think given that we're overrunning, I'm going to stop there. So thank you very much to everybody for their input. It was very interesting to hear everybody's perspectives on how to manage those things. I don't know if Shom is still around. I think we're going to finish it there, if that's all right, Shom.
Oh, that's absolutely great.